All right, so in addition to starting the recording, I'm going to take a quick picture of who is here so far, and then I'll do it again at the end to try to make sure I don't miss anybody for attendance. Then we can go ahead and get started. I guess it's 12:32. I'll give people one more minute to join. So they don't miss out on the beginning. All right, let's go ahead and get started. So today's topic is suicide prevention. And because it's so important, we wanted to make sure that everyone was kind of on the same page about the basics, which is why we made it mandatory this meeting. And the reason why it is this month is because this is Suicide Prevention Awareness Month. So this is exactly the right time to be talking about this. So we're going to start by looking at some charts about prevalence for suicide, because I think you hear a lot of different things about prevalence rates. So you can see from this first chart, you can see a couple things. You can see that the rates of suicide overall across all of these different age groups have increased since 2010. And you kind of see pretty consistent increase since then. So overall, we're seeing an increase in death by suicide. But otherwise, you hear conflicting things. You might hear that younger adults are more at risk. You might hear that older adults are more at risk. And the reason why you hear those conflicting things are because the data on thoughts of suicide, suicide attempts, and death by suicide are all different for different age groups and racial groups and gender. So it depends on what you're talking about, who's at most risk. So if you were talking about death by suicide, you see that middle-aged people are most at risk for death by suicide. That's definitely different than what we normally think of as we think of younger people being at risk, but they're actually the lowest in terms of death by suicide. However, if you look at this next chart, they are the highest group in terms of prevalence, with 10% of people aged 18 to 25 reporting suicidal thoughts in the last year. So extremely high risk in terms of having suicidal thoughts. They have a higher risk of suicidal plans, a higher risk of suicide attempts, and all of these are much bigger than the other age groups, but their death by suicide rate is lower. So that's why it's complicated. And I think that people get confused when they hear about the different risk factors and things like that. And I always find it's helpful to clarify, okay, like what outcome are we looking at? And there's a lot of different explanations for why we're seeing an increased rate overall of pretty much everything across most groups. So that more suicidal thoughts, more attempts, more death by suicide in the last few years. And then there's some debate about whether COVID increased that even more. Some people say that it's just more comfort with reporting, less stigma. More people are comfortable sharing that they have these thoughts or that they have these experiences. More families and more coroners are comfortable calling a death a suicide on a death certificate. Some people say it's that. Some people say that things in our society have become worse in terms of oppression and despair and economic pressures, things like that. And that has led to an increased rate of these experiences, both suicidal thoughts and deaths by suicide. We don't really know for sure, but we do know that it is, in some ways, especially for younger adults, a common problem. Right? When you see 10% of a population reporting something in the last year, definitely something we need to be talking about. So I also like to highlight the differences between thoughts and attempts. So a lot of people have thoughts of suicide. And if you think of this triangle, it's not proportional. I wish it was. That would make it more helpful to explain. The triangle isn't proportional, but what it's showing is kind of an escalation of different categories. So at the bottom, there's thoughts of suicide. And a lot of people have thoughts of suicide. So if they're looking at 18 plus self-report, they had 11 million people, almost 12 million people have thoughts of suicide. Only 3.5 million of those made any suicidal plans. Only about 1 million of those had a suicide attempt. And only about 50,000 died by suicide. So it's really important to remember that suicidal thoughts are not automatically connected to suicidal plans, attempts, or risk of death, because there are a lot of people, the vast majority, vast majority of people with suicidal thoughts do not have a plan, will not attempt, will not die by suicide. And I don't say that to minimize suicidal thoughts. I say that because I think it's important to have that context for what suicidal thoughts mean in terms of risk. And then overall, in terms of demographics, understanding the different rates. We talked about like how age can be complex. So race and gender can also be complex, but one of the riskiest demographics for death by suicide is middle-aged white men. So that's something that's been consistent for a while. And while they might not report as high rates of attempts, plans, or thoughts, in terms of risk of death by suicide, they're significantly very high, or consistently very high. And in terms of COVID, like I said, there's some debate about whether or not it's increased. But according to crisis hotlines, so suicide crisis hotlines, the demand in some places went 10 times as much. So people were calling in crisis more during COVID. And I think we just don't have good enough data yet to determine if that was also linked to higher rates of death by suicide. But I think we know for sure people were having more suicidal thoughts and were using crisis resources much more frequently. So what do we know about suicide from the research? So SPRC, Suicide Prevention Research Center, is my favorite resource when it comes to understanding the research behind suicide, which is obviously a very difficult topic to research. But we do know a couple of things about the decades of research that have been done on this topic. First, we know that suicide is related to differences in the way that your cognitive functions and behaviors are operating with your brain. So people who are having suicidal thoughts, and especially people who are having suicide attempts, the way that they're making decisions is distinctly different from the way that people who aren't in that state are making decisions. It's not off a rational state of mind. And I think this is important to understand because when patients talk about these experiences, they'll say things like, it didn't feel like me. I don't even remember what was going through my head. And that's because in some ways it's almost an altered mental state for a lot of people, especially if drugs and alcohol are involved, because that is literally an altered mental state. But it can't be treated as somebody who has the same decision-making ability and cognitive capacity in a normal mental status evaluation, because oftentimes people aren't in a place where they're able to have those decision-making skills. And because of that, research consistently shows again and again and again that if someone can get through the moments of active suicidal crisis, the strong urges to die, without dying, that they will not die by suicide in the future. So the risk is not constant. The risk is acute. It becomes very high. If people survive that time period without acting on those thoughts or without making a lethal attempt on those thoughts, they will most likely never attempt suicide again and not die by suicide. They are at increased risk, but the odds are that they will not die by suicide. So that makes intervention really important, because if we're able to intervene effectively in that moment, we can make a real difference in outcome. Research also shows that changing people's access to methods of killing themselves, so decreasing access to guns or other lethal methods, does decrease overall suicide rates. And that's because of what I just said. If you can get through the moment without killing yourself, and some people get through that moment without killing themselves because they don't have access to a lethal mean, they will most likely go on not to die by suicide. We know that treatments like medication and therapy are proven to help people manage suicidal ideation behavior. So this is treatable as a phenomenon. And we know that asking people about suicide does not put the thoughts in their head. It doesn't increase risk for suicidal thoughts or behaviors. If people don't want you to know, they're not going to tell you. And if you ask and they do want you to know, then that's usually a really good sign for help seeking in some way. So most people are relieved to have that conversation once somebody opens it up. So why do we talk about this in primary care? Why am I sharing this with this group of people in particular? So people are much more likely to see their primary care providers than they are to see me before they die by suicide. Twice as often people visit their primary care physicians before in the months prior to their death by suicide than they do with a mental health professional. So that's where people are having contact. And they have a pretty high estimate of people, and it's usually people trying to seek help. You know, they're trying to get all their options out on the table. Even if they don't bring suicide up, they're trying to feel better. And in contrast, only 20% see a mental health professional in the month before. And the fact is that most antidepressants are being managed by primary care providers. So most people who are depressed are at higher risk for suicide. That's who they're seeing for follow-up as well. So we need to be talking about this in primary care because this is our opportunity for intervention. This is our time when we can capture people because that's where they're coming in. And that's why we screen. So a reminder of screening at Neon. Excuse me. The PHQ-2 is done at every medical visit at Neon during triage for everybody 18 plus. And then we highly recommend also screening in pediatrics, especially when you think about how suicide is the leading cause of death, age 10 to 14-year-olds. Definitely something we want to be screening for. So not everybody gets screened for suicide. The people who get a positive PHQ-2 get the PHQ-9. And the PHQ-9 has an item that asks about suicide. It asks, how often do you have thoughts you would be better off dead or of hurting yourself in some way? So it's item 9. And I tell you that because I think it's every time someone hands me a PHQ, a paper one, or I'm looking at one in the chart, my eyes automatically go to 9 first. Because I just want to always make sure I'm checking out item 9. We don't want to miss this and see it later. So this is one of the big reasons why we want to review a PHQ-9 during the visit, before the visit, so that you can make sure you are looking at item 9 so that you can address that with your patient. Because for a patient, filling out paperwork that talks about suicide and then nobody following up on that is probably going to make them feel pretty hopeless. And not a lot of them probably wouldn't then bring it up verbally because they already brought it up. They already put it on paper. And they're waiting for you to follow up on it. So beyond screening is not enough. Lots of people who are having suicidal thoughts will not put it on the paper. I see it absolutely all the time. So we still want to ask about suicidal thoughts when we see the following things. I don't care what they put on the PHQ-2. So even if there's no evidence of depression with the screener, if you know and you're observing a lot of depression symptoms, if someone was recently hospitalized for psychiatric illness, sometimes even if there is a kind of like someone's following up after like a very suspicious accident, I mean, it doesn't make a lot of sense, like a solo car accident that drugs and alcohol were involved in, or an injury that, you know, could be related to wanting to hurt themselves. That's a good time to bring it up too. Anytime you're seeing severe agitation or acute emotional distress, you want to ask about suicide. Patients who are experiencing a sudden crisis, a change in life circumstances, that can be a good time to check in. Older adults with serious chronic health conditions who seem like they don't care about their health are often having suicidal thoughts. And there's a lot of research to back that up. And there's a lot of research that says we don't ask them about it enough. That population, people assume aren't having those types of mental health problems and don't ask about suicide. And really, patients with acute or chronic risk factors, which we're going to talk about more, but I would encourage you to ask about suicide when your gut tells you to. So there's a lot of different reasons why someone might be at increased risk for that. And sometimes you just get a gut feeling, and I don't think you can go wrong by asking that. If you're completely off base, the patient is just like, oh no, I'm not in that place. And then you move on. But it's kind of better to have asked than to not ask. So how do you ask about it? You ask about it directly. You do not use euphemisms. You don't beat around the bush. You ask about it directly, calmly, matter-of-factly. You don't ask about it like it's a really big deal or like it's a secret. You don't whisper it. You just say something like this. This is my phrasing that I use a lot. Some people in your situation may experience thoughts of wanting to die or wishing you were dead. Is that something that comes up for you? Or if you have some evidence that this has come up for them in the past, even though that's part of their history, I can say, in the past, I know that you have had thoughts about suicide. Is that something that's going on for you right now? Or when was the last time that happened? So this can be a very natural part of the assessment, even if it doesn't feel natural for you. With more practice, it will. But we want to ask the question explicitly. We don't want to try to guess what the answer is based on other things that we're saying, because let me tell you, there are plenty of times when I expected people to say no to this, and they said yes. So you can't always trust your assessment without explicitly asking for that information. So the model I want to use, I want you all to use for suicide assessments when it comes up, is called the SAFE-T model. It is a product of the Department of Human Health and Services, specifically SAMHSA came up with this. They have these little pocket cards you can keep in your desk. So if you would like one of these, please let me know and I will send you one through interdepartment mail, or drop one off in your office one way or another. And so I'm going to show you pictures on the slides, but these are their cool little laminated versions of it. It has everything that you need to know. Walk you through step by step, so you don't have to try to remember it all in the moment. So we're going to go through these 5 steps. All right, so we are going to identify chronic risk factors. So I have a list here of chronic risk factors. I'm going to go through them pretty quickly because I want to make sure we don't spend too much time here. Gender, men are much more likely to die by suicide than women. Psychiatric disorders, not just mood disorders, any psychiatric disorder. A personal history of suicide thoughts and behaviors, history of abuse, family history of suicide, chronic pain, and being LGBT. So these are called chronic risk factors because they don't go away. These are things that if you have, it kind of adds a little check in the chronic risk factor problem. It does not mean that everybody with these risk factors is suicidal, not at all. But it does mean they're increased risk for having suicidal thoughts. And you want to weigh that in your assessment and understanding of their risk. You want to pay attention to these chronic ones, and then you also want to pay attention to acute risk factors. Those are things that are going on right then that increase risk for suicide, and specifically increase risk for acting on suicidal thoughts. Current substance use, stressors that are active and ongoing right now, especially really big ones like a financial crisis, a housing crisis, a relationship crisis, access to firearms. Some specific symptoms have been linked to an increased risk of suicide attempts, like impulsivity, command hallucinations, lack of sleep, and agitation are associated with a higher risk. A new health diagnosis, and obviously the one that everybody knows about is having recent thoughts or behaviors, especially recent attempts or rehearsals. So rehearsals are when people go through the steps. They maybe get the gun, they hold the gun up to their head and see how they feel. Maybe they write a letter to their mother, or maybe they go to the bridge where they're thinking about jumping off. They don't do anything, but they practice or rehearse the suicide attempt. And one I really want to highlight, because the research consistently identifies this as the highest risk time for suicide is the months following discharge from a psychiatric hospital. And that's really important because we get those referrals and follow-ups for physicals and mental health evaluations when people are discharged from psychiatric hospitals at Neon. And there's a lot of responsibility for that because that is the highest risk time for people to die by suicide is in the months following that. So we want to pay extra close attention to those patients. We also want to look at protective factors. So it's not just about risk. It's also about protective. So these are things that are internal, like coping, religious beliefs, etc., or external, responsibility to others, positive relationships with caregivers, social support, treatment that decrease risk. Now, it's not always an even weighing. So when someone has a lot of acute and chronic risk factors, protective factors aren't going to cancel that out completely. You always want to pay most attention to the acute risk factors, but you should take these into account too. All right, so once we have identified that suicide is a concern, we've asked the question, and they've said, yes, they have some of these thoughts. You want to ask some more questions. These are some of the questions that I like to follow up with. I like to start open-ended because they're going to tell you a lot of what you need to know. So tell me more about those thoughts. It's helpful to get time period, like when did they last occur? Sometimes people are about to tell you about suicidal thoughts they had 20 years ago, which is very much not acute. And that would be helpful to know. So you want to get timeline. But I start open-ended so they can tell me, and then I follow up with the details. To ask about plan. So I have a little graphic on the left here. Thoughts of death, ideation, plan, means, intent. These are all the things that are part of a suicide assessment. So once you know about thoughts, you have to assess for everything else on this list. And these questions are a way for you to get there. So one of the ways I assess for plan and for means is by asking, do you think about how you would kill yourself? And what is the closest you've ever come? Those are very helpful at getting at some of those ideas. And then to get it intent, you can just get right to it, be direct. On a scale of 0 to 100, how likely are you to act on these thoughts and try to kill yourself? And the patient will tell you. And then you can ask why they gave you that number. And that'll give you a sense of risk and protective factors as well. If patients aren't able to tell you any reason why they haven't killed themselves, that's very concerning. And it's definitely going to lead to a higher risk evaluation. Because the whole point of asking all these questions to do this evaluation, and again, all those steps are on the card, so you don't have to memorize them, is to determine risk level. So you're going to take all the information I just talked about, and you're going to integrate it, synthesize it into understanding whether someone is at high, moderate, or low risk of suicide. And this changes, it's not static. I see somebody someday and they might be moderate to high. I have them come in a few days later and they're more moderate. In a couple weeks, it's low. So this will fluctuate. And honestly, sometimes I think it fluctuates hour to hour. But in those cases, that's usually a higher risk person because there's so much fluctuation. And this provides some descriptions of what a high, moderate, or low risk person would look like in terms of their risk and protective factors. I'm not going to go into depth on that because it'll be on the card. You'll be able to see it. And the reason why that matters, why we want to know about risk overall, is because that's going to inform your intervention. Because we don't do the same intervention for all people with suicidal thoughts. It's going to vary based on their level of risk. So what are interventions for suicide? For high risk, that's when you're considering emergency hospitalization. You're involving friends and family to help transport or get to the hospitalization. You're thinking about inpatient. I prefer to get people to inpatient directly when they're interested in inpatient. If they're like, yes, I would like to get inpatient treatment, because sending them to the ER very rarely gets them connected to inpatient treatment. So even though I think when people are most scared, that's when they go to the ER, if we can get somebody straight to inpatient treatment rather than go to the ER, that's a much more efficient way to connect them with what they need. And we don't expect you to be dealing with high-risk patients without consulting with behavioral health. I really hope that you are able to consult with us on these patients so we can help you through it. But just in case we aren't available, I think it's important to know what some of the options are. So that's when you want to be considering emergency hospitalization for those highest risk patients. For moderate risk, you got some more flexibility here. You still want to be involving friends and family and the treatment team and safety planning, and I'll talk more about that in a minute. It's really important to be treating the underlying psychiatric conditions that are there. So if there are underlying psychiatric conditions that are not being treated, we need to make a plan to address those because that will reduce someone's overall risk level. You want to consider levels of care like intensive outpatient treatment. So that is a step in between intensive treatments like inpatient and outpatient where you're seeing somebody once a week. It's more monitoring, it's daily or sometimes several times a week, and it's for hours, includes a lot of groups. And again, Highland Springs and recovery resources are possible referrals for that if the patient is interested. And ideally, we want to come up with these plans with patients getting on board with whatever they want to get on board with. When they're not on board with it, that becomes a lot more difficult. But for low risk or moderate risk, there is some flexibility there. For high risk, we may still have to do something to keep people safe, even if they aren't on board with it, which is when emergency hospitalization comes into play. So for low risk patients, which is going to be most patients that you see with thoughts of suicide are going to fall in the low risk category. Treating psychiatric conditions is the top priority. So the Joint Commission actually mandates that all patients who report suicidal ideation get the 24-hour emergency number. So the National Suicide Prevention Lifeline is something that you should have hanging in your office. And in the follow-up email that I'm going to send today, there'll be a poster that you can print out and put in your office. So all patients who report suicidal thoughts should be given that hotline. That is really important that we're doing that as a minimum. We want to be encouraging them to address those underlying conditions and consult with behavioral health and maybe do some safety planning, which I'll talk more about what that looks like, especially if they're interested. But again, we don't want to be hospitalizing or sending people to the ER who are low risk. That doesn't make a lot of sense. We want to be appropriately matching our intervention to the level of risk, and this model helps you do that. And a lot of patients are really scared of being sent to the ER. So when we start talking about that for people who are low risk, all we're telling them is that it's not safe to share your thoughts with us now. And they're going to never tell you that ever again. All right, so other interventions that we can do besides just referring people to different levels of care. We can talk about means restriction. It's a fancy word for saying getting the things that can kill you harder to get to. It can look like a couple different ways. A lot of times people are talking about gun storage. So using gun locks, sorry, typo there, a lockbox for the gun, keeping ammo and the gun separate, or not having a gun at your house, having your gun be held by somebody else when you're having a really hard time with your mental health. So anything that makes the gun harder to get to is a means restriction intervention that has proven highly effective at preventing suicide, especially because if you look at this graph here, 50% of suicides are with a firearm. So if we're addressing guns for people who have them, you got to ask first, do you have access to a gun? And then start talking about this. The other thing we could do means restriction for is medications that people have access to if they're thinking about overdosing on them. This is another common plan that people have, especially young people. We can put those medications in a lockbox. We can talk with family or the patient about getting rid of some of the older medications and taking them to the pharmacy to dispose of them appropriately, or again, having somebody else take care of them. But all of those are ways so that when a person is in a crisis, they don't have access to lethal means, they'll get through it and hopefully survive. Other interventions, if you have time and you have interest, I highly encourage you to experiment with doing safety planning with patients. This is appropriate for all levels of risk. A safety plan is basically this idea of when you have suicidal thoughts, what should you do about it? And I have a template here that tells you exactly what to put in. So when you have thoughts of suicide, what are some coping skills you can do? What are things that help you feel better? Who are people or things that you can do to provide distraction? Also, the first category is warning signs. So things that indicate that suicidal thoughts are coming so that you know you need to pay attention to your mental health. And then we've got people who you can ask for help, people and agencies you can ask for help. And then you have making the environment safe, which is means restriction. And then the last step is things that are important to you and worth living for. So you can fill out a safety plan with the patient in 10 minutes. And that is different than a safety contract. People might have heard about suicide contracts. That used to be really popular, where we would ask people to promise that they won't kill themselves. Research shows it didn't work at all. And it's just really disingenuous, because if patients can't promise you that and they're promising you that just to get you to stop talking to them, it kind of does the opposite of what we want to do, which is engage them in ways to keep themselves safe. So instead of making people promise things about safety, we're actually talking about how to increase safety by coming up with a plan. All right. One more thing that I think is really important when we're talking about this, that a lot of you worry about, is risk management. This is a risky thing that we're dealing with. And the most important thing we can do for risk management is document, and document thoroughly and appropriately. You really want to make sure that anytime a patient has a positive PHQ-9, that you have documentation to show what you did. So anytime a patient said that they had suicidal thoughts on the PHQ-9, on that item number 9, you want to make sure you have some documentation of how you addressed it. I have some smart phrases here that you could put in your note. So as you always, you'll get a copy of the slides, so you can copy and paste these out of the slides. And you just want to say like what your assessment was and what your plan is to address those thoughts. You don't want to leave it blank. I'm going to skip through this because I'm not sure I have time to give it justice, but I want to just point out that there are evidence-based interventions that reduce suicide, and they're actually really straightforward. This was a really cool study that targeted older primary care patients. And basically, when we prescribe appropriate medications for depression and we follow them closely and make sure they're doing them, they're taking their medications and they're getting therapy if they want therapy, and we'll make sure they come to their follow-up appointments, they're much less likely to die by suicide. It's as straightforward as that. Like, appropriate management of depression will reduce suicide when done collaboratively. Antidepressants, a lot of people get worried about the black box warning, as you all know. That's something patients get concerned about. That's something providers are concerned about. And I think it's really important to remember about the black box warning for increased risk of suicide with some types of antidepressants, is that it only applies to those 24 or younger. So it doesn't apply to all age groups equally. It is a specific risk factor for a specific age group. And overall, population-based studies show that antidepressants decrease risk of suicide. So some people see the black box warning and they're like, why would we give this medication that increases risk of suicide? It's more nuanced than that. Overall, it decreases risk of suicide. But for some small portion of younger adults, there is a higher risk of suicide after initiation, after discontinuation, and changes in dosing. So not the whole time, but during specific periods. And it doesn't mean we shouldn't try antidepressants with these patients. It means that we should monitor them more closely when it comes to suicidal thoughts during those high-risk time periods. These are some tips that I found about how to manage risk appropriately for managing suicidal patients, which I think is mostly more relevant for psychiatry, but it's relevant for us too. When we are managing patients with chronic suicidal ideation, we should be doing similar things. So this is a list of things that people do get sued for and get in trouble for when it comes to a failure to provide appropriate care. So these are the most common reasons that people get in trouble for not following appropriate care guidelines. failure to hospitalize, failure to diagnose, failure to take appropriate protective measures or develop a comprehensive treatment plan, failure to communicate with other providers, failure to get an adequate history, failure to review prior medical records. These are the type of things that might add up to neglecting your duty to the patient when it comes to diagnosing and managing suicide. And that's all I have. I appreciate you all staying with me today. And I know that a lot of you have to go do lunch. Let me stop screen sharing. But if anyone would like to stick around with questions, I can see that somebody, Dr. Peacock said in the chat that she would like one of these. Absolutely. I'll make sure you get one. They're pretty nifty. So I want to open it up to any questions, clarifications that people have. You can also order these. These are Suicide Prevention Lifeline wallet cards. They're free from SAMHSA as well. And that way you can just give them to people instead of having them write down the number. I often tell patients to put it in their phone because then they'll always have it. So I'll stick around for a bit to see if anybody has any questions. Oh, I'll also stop recording.